Okay, this is the second report. Management of patients with urinary problems, starting with urinary tract infections. And second most common reason patients seek health care, I think we said that in class. Common site of health-acquired infections. We divided them into lower urinary tract infections such as cystitis, prostatitis, urethritis, and then upper urinary tract infections such as pyelonephritis, acute and chronic. We didn't talk about intestinal nephritis, renal abscesses, and perineal abscesses, so they are not on the exam. Factors that contribute to UTI, talks about functions of the glycosaminoglycan. We're not going to, don't worry about it. Uretrovesical reflux. Uretrovesical reflux, I think we talked about this. Uropathogenic bacteria. Shorter urethra in women, and there were risk factors that we outlined. Okay, again, nursing care of the patient with a UTI assessments. Symptoms may include pain, burning upon urination, frequency, nocturia, incontinence, suprapubic, pelvic or back pain, hematuria in some severe cases, and of course a change in urine and urinary pattern, and some asymptomatic. Assess voiding patterns. In other words, how many times do people void? Like we say, some people will hold the urine and only void once a day or something like that. Association of symptoms with sexual intercourse, contraceptive practices, for example, women using diaphragm, personal hygiene, gerontological consideration, as I specified in your book, assessment of urine, urinalysis and urine cultures. Other diagnostic tests may be necessary. Diagnosis: acute pain, deficient knowledge, sepsis, renal failure. These may be potential complications. Major goal may include relief of pain and discomfort, increased knowledge of preventive measures and treatment modalities, and absence of complications. Prevention: avoid indwelling catheters, care of catheters, personal hygiene, medication to be taken as prescribed, such as antibiotics, analgesics, antispasmodics, application of heat to the perineum to relieve pain and spasms, increased fluid intake, avoidance of urinary irritants such as coffee, tea, citrus, cola, and alcohol, frequent voiding, patient education. You can read the question. We didn't do urinary incontinence. Urinary incontinence, this is an undiagnosed and underreported problem that can have significant impact on the quality of life and decrease independence, which may lead to compromise of the upper urinary tract system. Urinary incontinence is not a normal consequence of aging, right? Not, just because people are old, it doesn't mean they should be incontinent. There are risk factors that lead to incontinence, such as stress, in terms of, for women, having, probably multiple children becomes a risk. Types of urinary incontinence: stress, age, reflex, overflow, functional, iatrogenic, mixed incontinence. Okay, patient teaching: urinary incontinence is not inevitable and is treatable. Management takes time. Provide encouragement and support. Develop and use a voiding log or diary. Behavioral interventions, medication teaching related to pharmacologic therapy, strategies for promoting continence, such as the Kegel exercises. Okay. Like I said, urinary incontinence is not on the test. Urinary retention: inability of the bladder to empty completely Residual urine is the amount of urine left in the blood after voiding. Causes include, age, 50 to 100 million adults older than 60, due to decreased trexor muscle activity, diabetes, prostate enlargement, pregnancy, neurologic disorders, and medication. In other words, what this is saying, those individuals that are listed can have a residual volume of urine of that amount. Okay. Assessment measures to promote voiding. Measures to promote voiding, and like we said, urinary retention is usually done post voiding. Can be done, in patients that are suspected to have retention. Can be done after, a Foley catheter has been removed, just to check to make sure that the patient is not retaining any urine. So any residual above 50, there will be parameters from the urologist to say if it's above so much, probably reinsert the catheter. Okay. Urolithiasis and nephrolithiasis, these are calculi or stones in the urinary tract. Like we said, causes may not be known. Manifestations depend upon location and presence of obstruction or infection. Usually the main thing, like I said, pain and hematuria. Whether the stone is in the bladder or in the kidney, its presentation is going to be different. Okay. Diagnosis is usually X-rays, blood chemistry, stone analysis, strain all urine, and save all stones. Okay. That's diagram is just showing potential size of stones, the kidney itself, the ureter. Methods of treating renal stones. The first one is using a cystoscope, where they go and retrieve the stone. Okay. And this one is the lithotripsy, where they are using shock waves. Okay. And then this one is percutaneous retrieving of the stone. So it depends, like we said, on the size of the stone. Patient monitoring includes teaching signs and symptoms that they are to report about pain, follow-up care, urine pH monitoring, measures to prevent recurrent stones, for example, encouraging fluid intake if they are not, dietary intake. Remember when we talked about stones, there were some stones that were caused by high intake of protein, uric acid, green, leafy vegetables. Medication teaching is indicated. Talked about urinary diversion. Main reason for urinary diversion is blood cancer or other pelvic malignancies. Could be due to birth defects, trauma, strictures, a neurogenic bladder, chronic infection. Okay. It's used as a last resort where there is incontinence. Okay. We talked about the different types, the diversion of the ureters with the ileoconduit, nephrostomy, and then where there's the continent urinary diversion, where they create a reservoir with the Indiana pouch, cork pouch, and then ureterosigmoidostomy. Miss Judy talked about that one in her video, where the ureter is actually transplanted into the sigmoid. And those are the diagrams. I hope they are clear. Of course, nursing diagnosis would include pre-operatively anxiety, imbalanced nutrition, deficient knowledge, post-op risk for impaired skin integrity, acute pain, disturbed body image, potential for sexual dysfunction, deficient knowledge. And that's it. Like I said again, this is supplementary, just to help as you are studying. It's not, like I said, This is all from Bruna. The slides are from Bruna.